on the News Channel 5 network. This is Open Line.
Hello, everyone. Welcome to Open Line. Glad you are with us tonight. It is Tuesday, July 21st. And what we're going to do tonight is really just try and get the most up-to-date, the most accurate information when it comes to the coronavirus. How long will this pandemic last? And where are we as far as a vaccine is concerned? We are very lucky to have with us a senior scholar at Johns Hopkins University at the Center for Health Security. He's joining us via Zoom, as all of our guests do now, from New York City. So I want to welcome Dr. Amesh Adalja, again, senior scholar, Johns Hopkins Center for Health Security. Doctor, thank you for being with us.
Thank you for having me.
All right, question number one, and I have a lot of questions, but how long do you think we will be in a situation here in this country where masks will be required? Is this a short-term thing that we are looking at, or are we really in this for the long term?
I think unless there is a vaccine developed quickly and put into the arms of Americans, that masks are going to be something that are very much normalized. This is going to be something that we'll do everywhere we go, anytime we're indoors, because there is this real concern about this spreading, and face coverings do have some benefit in preventing people from spreading this virus. And I think you're going to see policymakers continue to stick to the mask mandates until there is a vaccine. And I think that even after that, I think there's going to be people that get comfortable with masks, and they may use them much more frequently, like they do in Asian countries just during flu season, to decrease their risks with flu as well.
Now, all right, your work is focused on emerging infectious diseases, pandemic preparedness, and biosecurity. So we have been planning for a pandemic for a long time, and my question is, now we're in one. Is this worse than some of the pandemics you might have expected? Is it different? And I ask that, you watch maybe some movie like Contagion, and it seems like somebody gets it and they die. This has been a little more sneaky in that there's so many people who don't die, but does that make it in some ways easier to dismiss and maybe more dangerous on some level?
Each pandemic is unique and has its own specific challenges. This one is not the worst case scenario because the case fatality ratio, how many people die that get infected, is likely less than 1%. Not like what we see with bird flu, where it might be 60% of people who get infected may die. So in that sense, it's not fatal in that sense. However, it is a new virus that no one has any immunity to. So even if it is a small percentage that die, it's still a small percent of a big number, and it's a big number. And I do think that this pandemic has been made worse by bad public policy decisions from the outset that have compounded what the virus itself was doing. And I think that's really going to be the story of this pandemic, is the mistakes that humans made to accelerate this virus, to amplify its impact. And that's really the opportunity we have to get it right by looking at our mistakes and trying to figure out exactly how we will never let this happen again.
What is the number one mistake, if we could go back and correct things, what's the number one mistake that was made globally and I guess here in the United States?
I think the number one mistake was evasion, that there was just this failure to recognize what this virus meant. This is a respiratory virus that was spreading efficiently, person to person in China, and we knew that as early as January. By definition, by any textbook definition, this was going to be a virus that was going to come everywhere and be everywhere in the world, and likely already had spread out of China before that. And we've actually found that out, that this was already in France in December, and in Italy in December as well. So this was something that wasn't going to be able to be kept in one place, and likely had already gotten to the United States by the time we even started preparing for it. So that meant we needed to take our focus away from thinking about travel bans and quarantining people on Air Force bases and getting our hospitals ready, making sure they had enough personal protective equipment, making sure they had enough mechanical ventilators, getting the vaccine developers going, and especially, and this is going to be the original sin of this pandemic, diagnostic testing. Having the private sector get engaged very early to make tests instead of relying on a CDC test that ended up being flawed and put us way behind, where we didn't know who was infected and who wasn't infected. And governors were left in these really precarious positions where they thought the only solution that they had was a stay-at-home order. It didn't have to be like this. We could have had a Taiwan experience where there was a minimal disruption.
So here we are right now, where New York was really bad. They've come through that. Now it's spreading. There's no doubt about it throughout the South. How do you assess where we are right now? Are we on the verge of pushing this back? Are we on the verge of something really bad? Kind of where are we right now with this virus?
In some parts of the country, it is going to get worse before it gets better. There are places in the Northeast, like New York City, that have done fairly well and have contained this virus as best as it can be contained. But there are other places where this virus is spreading rampantly, where the percent positivity of tests is rising, where hospitals are again worrying about ventilators and ICUs and having enough of their workforce in place. This is going to take some time to turn around. Every action we take with this virus, it takes about 2 weeks to actually see the effect because of the incubation period. So it is going to be some time before places like Texas and Florida and California see the light again. And it's going to be dark days in those places, and especially for those healthcare workers that are going to be seeing patients getting admitted to the ICU, being gravely ill, and some of them dying. And I think that what we've seen here is that these states where you're seeing these new hotspots made the same mistakes that the country as a whole made in January, February, March. The whole thing is replaying now at a state level.
And one thing we hear is about herd immunity. And when you hear that said, it's something along the lines of everyone's going to get this. Why don't we just let everyone get it, and then we will develop herd immunity? What are your thoughts on that?
So herd immunity for this virus, based on its contagiousness, requires maybe 60% of people to get infected. In order to do that, if you let the virus run rampant, you are going to kill a lot of people because there are so many vulnerable people in the United States. Maybe 1 in 5 have some pre-existing condition that puts them at higher risk for death, like obesity or diabetes or hypertension. And there are many elderly individuals who are very susceptible, and that curve starts to rise around age 50. So if you explicitly pursue a herd immunity strategy, the way Sweden somewhat did, you will take a hit in the number of deaths that you cause. So I don't think that herd immunity is the best way to go about this because we can't protect the vulnerable population so well. We can do it. We're doing a much better job now in July than we were in March at nursing homes, because nursing homes accounted for 40% of our deaths. But there still are too many vulnerable people in the population, and it's unlikely that this is the best strategy. We will get herd immunity, but through a vaccine. So I think we don't, but it's not a false alternative between herd immunity, letting the virus run rampant, and putting everybody in a stay-at-home order and shutting every business down. There is a better way to do this, and I think we can learn from the lessons from the earlier part of this pandemic, as well as other countries, and be very targeted with our public health approach to those activities that are actually spreading the virus, and give people the tools to be able to reduce the harm that the virus causes in their lives.
The head of the CDC said this was going to be a dark winter and fall. Do you agree with that assessment, and why? Why would that be the case?
I do agree that we have to be prepared for a very dark winter, because what's going to happen is that this virus, it's a coronavirus, and we know biologically that coronaviruses tend to accelerate their transmission when it becomes colder, when it becomes less sunny, when it becomes less humid. This is respiratory virus season. And at the same time we're dealing with the coronavirus, we'll be dealing with influenza, which comes around every year. And it's going to be the two viruses competing for the same bed space in hospitals, the same ventilators, the same personal protective equipment, and the same attention from healthcare providers. So this is going to be two respiratory viruses basically vying for control of this respiratory virus season. And it's going to be challenging to be able to distinguish the two, because they're not clinically distinguishable, and we don't have the diagnostic testing to be able to do it very quickly to know whether or not someone has the coronavirus. And then to think about what might happen if hospitals are inundated with both flu patients, and sometimes we get 80,000 flu deaths in a year. It could be really bad, and I think that's something we have to prepare for. And everybody that's listening should think about getting a flu vaccine when they're available, so we can keep people out of the hospital with influenza, so we have room for the coronavirus patients.
One of the things, again, you focus on emerging infectious disease, pandemic preparedness. And when you look at this pandemic, another thing that strikes me is that children don't seem as impacted health-wise. And again, I wonder if that leads to a sense of this isn't as serious as it could be. I mean, how unusual is it for a pandemic to not impact children like this one, I guess as severely like this one has?
It is unusual, and it definitely has gauged the way we've responded to it, because it's very different when the average age of death of a person in this pandemic is in the 70s versus if it was 16, for example, or even younger. That's going to have a whole different societal response. And it is true that this virus isn't an equal opportunity killer. Tends to kill people that are older, that have other medical conditions, and children tend to be very less represented among hospitalized cases or those who have severe infection, or even those who even have symptoms of the disease. Although there are some rare cases of inflammatory syndromes that this virus can trigger in children, it's not the norm. And I think that's, in one way, a silver lining, because that gives us a way to think about opening schools and getting back to some semblance of normalcy. But it is something that has also change the way that we think about this pandemic. Even if you look back to 2009 H1N1, the average age of death there was in the 30s. That's a very different type of pandemic, and it takes a very different toll on society versus a pandemic that is largely killing people that are sort of at the end of their lives.
I feel like, and maybe I misunderstood things, I feel like when this first started in March, frankly, I was a little surprised. Everything was canceled. We all went home. We were told to self-quarantine. I felt like it was self-quarantine for a couple of weeks, for a short period of time, and we'll get over this. And I don't know if that was just the message I heard and I misunderstood, but I feel like a lot of people felt that way. What you're saying is that what we thought then? Or was that misrepresented? Or did I misunderstand it? It seemed like that was the message back then in March. Go home, self-isolate, and we'll get over this, and then we'll go back to our lives.
That wasn't the real message, and I think it probably got distorted, and there was a lot of miscommunication about this. This is a virus that transmits so efficiently that it established itself in the human population. It wasn't going to go anywhere until we had a vaccine. The stay-at-home orders in March and April were not about eradicating or eliminating the virus. What they were about was preserving hospital capacity, trying to just flatten the curve so that it stayed underneath hospital capacity. And then, as we realized hospital capacity was okay and not everything that happened in New York City was extrapolable to the rest of the country, you started to see states lift restrictions, and this virus was still there, and any amount of social interaction is going to be an opportunity for this virus to transmit between people. So it wasn't going to go anywhere, and there was never going to be any plan other than a vaccine to rid ourselves of this virus, because it is so well established in the human population and transmits so efficiently.
I'm going to ask about
this is a seasonal virus. It's what we would say is endemic. It's endemic in the human population now. Wow.
I'm going to ask about vaccines in a moment. Our mayor here has just said that bars will close after 10 p.m. I guess, and so I want to get back to this fall and winter. What will our lives nationwide, is what you can speak to, look like? Do you think we can have school? Do you think we can have sporting events? Do we have to shut everything down? What do our lives look like from now until the end of 2020?
I think our lives are going to be a new normal. You're going to see people that are wearing face coverings. You're going to see people trying to social distance. You're not going to see crowded scenes and big events with more than 200 people in them. You're not going to see packed stadiums cheering on teams. It's going to be a different type of normalcy that we're going to get used to, because this virus is not going to go anywhere. I do think that we can, in many places in the country, open schools safely. Those schools are going to be modified with a lot of social distancing in them. We will see sports, but likely without fans, like we're already seeing with the Major League Baseball, with the PGA, with the NBA gearing up as well. So we'll have modifications of our normal life. What you remember is, because the virus is here, any type of mass gathering is going to be an opportunity for the virus to really super spread. And if you're a contact tracer working in a local health department, it's going to be impossible for you.
We definitely don't want you to freeze.
More medication.
Okay, all right, you're kind of cutting in and out there, just that last part, but I understand. It's going to be a dramatically different fall and winter, a new normal for us. Then my next question is, where are we with a vaccine? So where do things stand right now with a vaccine?
So we are moving faster than we ever have with any vaccine. This is something that we usually measure in years, and we're trying to make a vaccine in months. So that really gives you the key to this, is that we although we're moving very fast, it's still something that we have to be prepared to deal with without a vaccine for some period of time. We have vaccines that are in late stage clinical development. We've gotten good data even this week from phase 2 clinical trials. Everything is looking good, but you have to remember we have to get through phase 3, which is where you actually see if the vaccine works. We have to understand how safe it is, and then we have to scale up manufacturing to a level to be able to put this into the arms of every American or every person on the planet before this stops being a threat. So I do think we probably have a period of maybe 2 years before we have enough people vaccinated. There will be some vaccine that trickles out where people will be able to get, if they're a high risk person or a healthcare worker, they may be able to get vaccinated early. But I do think that although we're breaking records, we have to be prepared for slowdowns that may occur as we get further into development. And
see, that's another thing I don't know that people have heard, and I don't know that I've heard it. So you're saying it may be 2 years, which makes sense. I mean, what I've heard is the earliest we'd have a vaccine. You keep hearing people say, well, we may have a vaccine maybe by the end of the year or right at the start of the new year. But if we have a vaccine, we then still have to distribute that vaccine, right? So, I mean, even if we have it, it may be, you're saying 2 years before everyone's vaccinated and this is behind us. Is that what you're saying?
I'm saying 2 years, that it's a period of probably 2 years to get enough vaccine immunity to be able to reach the herd immunity threshold. If there is, if everything, that's just me trying to be overly cautious and not overpromise, because I don't want people to think we can just kind of forget about doing what we need to do now because the vaccine is on the horizon and it's coming and it's imminent. And we don't need to worry about diagnostic testing or personal protective equipment or making sure our hospitals are okay. We're still going to have rough days ahead, and we're not going to have a vaccine to help us out of this. And if there is a glitch in the vaccine, if there is some problem with manufacturing, we need to still have the basic infrastructure to be able to deal with this virus as if we didn't have a vaccine. Hopefully we'll get a vaccine. I believe we will have a vaccine. I'm confident in the process, but I don't want to overpromise and say we're going to have it by this certain date, this date certain, and then it not come about because of some manufacturing glitch that happens or some signal in a phase 3 clinical trial that we didn't anticipate. We do have multiple candidates. We are doing Operation Warp Speed to start making vaccines before we know that they work. So there's a lot of good things in this whole vaccine development that may get it to us quicker, but I just want to be prepared because it would be an historic delivery if we get a vaccine as quickly as some people are promising.
That would be a historic delivery if we get it. Then we have to distribute it. And again, part of what you've done, pandemic preparedness, I'm sure that's part of the pandemic preparedness. So let's say we have a vaccine. It's safe, but now we have to get it to everyone. What are the challenges there? I mean, are we prepared to do that? And how difficult is that going to be to distribute this vaccine to get to that herd immunity you were talking about?
I think in this country, it'll be relatively easier than, for example, doing it in sub-Saharan Africa, where they have a hard time even delivering measles vaccines. But I do think it's going to be challenging, and we're going to have to look to the 2009 H1N1 pandemic vaccine rollout to see the best way to do this. We may be using doctors' offices, health departments, schools, places where people will just get vaccinated. And it's not going to be everybody all one day is going to go line up and get their vaccine. Like I said earlier, it's going to be tiered likely based on high-risk groups getting it first, and then maybe healthcare workers and then other people. So there's going to be sort of a phased distribution of it. And then there's also the concern is it the best thing to vaccinate your entire country or to vaccinate the healthcare workers and high-risk populations all over the world first? So that's going to be a debate that actually happens as well. Is there going to be vaccine nationalism or vaccine diplomacy? And that's something that we're going to have to contend with. So during H1N1 in 2009, Australia had the first vaccine, and they did not allow it to be exported until they vaccinated their entire country. So that may be also the scenario we face again if maybe England makes the first vaccine or China makes the first vaccine or some other country makes it, or if we make this other country, there's going to be hard decisions to be made.
That's interesting. So it does matter who makes it first. Do you feel like, how are we doing in the United States? Do you feel like it'll come from the United States or will it likely come somewhere else, or do you have a sense on that?
It's hard to say exactly. We have so many candidates, and some of them are partnerships between American companies and other companies. But I do think that the United States has a lot of candidates in development that are looking good, and so does the United Kingdom. I think the big news this week was from the United Kingdom's vaccine, the AstraZeneca Oxford University vaccine, which looks really good and has animal data behind it as well, meaning they tried it in animals, and it seemed to work pretty well in that scenario. So maybe I would say that the United States and England are both in the lead right now, although China has a vaccine they're giving to their military. So they may be in the lead if you look at it that way.
What about cost? Do you have a sense of that? Is that something that is not going to be a problem, or is that something that it may be very expensive? How do you deal with cost when you're planning for a pandemic? And I know you don't know the exact vaccine in this case, but what do you think as far as cost?
What I think will happen in the United States is that this will be something that is covered by taxpayer funds. This isn't going to be something that an individual pays for out of pocket. It's going to be more difficult when we're thinking about the developing countries and how they're going to afford to purchase that vaccine. And that's where the Bill and Melinda Gates Foundation and other foundations are probably going to bridge that gap for the developing world. But I do think here it's going to be something that's available free of charge, similar to what the 2009 H1N1 vaccine was. Not necessarily free of charge because it's being paid for by taxpayer funds, but not anything out of pocket when you're getting it.
You keep mentioning H1N1, and I remember that, but obviously it wasn't anything like this. It didn't seem to me to be anywhere near as severe as this. Is that true? And what would you compare this virus to in history?
So H1N1 was a pandemic that occurred in 2009. It was the last pandemic before this one, and it was our latest flu pandemic. This was a virus that emerged, a flu virus that emerged from Mexico. It was a swine flu virus, meaning it emerged from pigs, and it spread into the United States very early on, just like you would expect. And we got wind of it around April of 2019 when 2 young girls were sick in the San Diego area. And before you knew it, this virus was everywhere. And there was a lot of panic early on because this was influenza. And we know that influenza back in 1918 caused a cataclysmic pandemic. So people were worried, and we had these early reports of people being very, very ill in Mexico. But quickly we found out that this wasn't as deadly. We were kind of getting a skewed picture by just looking at hospitals. It's called a severity bias. We were getting a sample. We were looking at things that were severity bias because the news is always going to cover the more deadly cases and not the mundane cases. So initially there were schools closed, people were worried, there was runs on Tamiflu, but then that all dampened down when we realized that this virus wasn't so deadly. It was still going to infect a lot of people, and I'll get to that in a second, but it wasn't killing at that high of a rate. It actually killed at a lower rate than seasonal flu. But it was a new virus. It infected 61 million Americans in a year. It was something where the average age of death was 37. It spared the elderly. It really went after this age group of people that were born between 1957 and 1968. It really went after after these age groups. It was an interesting demographic, and that's why it wasn't as deadly as prior flu pandemics.
That's fascinating. This pandemic is deadlier. Would you say this is worse? And what might you compare it to? Is it going to be as bad as what we saw in 1918, or you wouldn't say that, or what would you compare this to?
So this is a totally distinct virus. It's not an influenza virus, a whole different family, coronavirus, and we don't have any known coronavirus pandemics in history. There probably were, because 4 of our coronaviruses cause about 25% of our common colds, and they may have caused pandemics when they first jumped into humans. But this is something, it's definitely worse than 2009 H1N1, but it's not near the 1918 pandemic, which killed maybe 100 million people in the world. This is probably somewhere around the 1968 flu pandemic, which killed about 100,000 Americans. So it's a little bit worse than that. And I do think, we're much better off than we were in 1918. In 1918, we didn't even know influenza was caused by a virus. We had no flu vaccine. We had no antiviral. We barely had any kind of hospital level care, let alone ICU level care. So I do think 1918 is really something that is kind of off the scales when it comes to pandemics.
Fascinating discussion. Okay, I appreciate you being here. We're going to take a break and start taking calls. So Ann, Tom, Leon, I believe, hold on the line. If you want to call in, there's the number, 615-737-PLUS, 615-737-7587. We'll take a break. Be back right after this.